Welcome. I am Dr. Gurpreet Singh Pata. Today, we step beyond the clinical surface and into the complex scientific landscape of CRPS. Often called the suicide disease, CRPS represents a failure of the nervous system to regulate pain, reaching levels few other conditions can match. On the McGill Pain Index, CRPS ranks at the absolute top, scoring higher than the pain of childbirth or digit amputation. This is not an exaggeration. It is a clinical measurement of a level of suffering that fundamentally rewires the human experience. Our understanding began in the trauma of the American Civil War, documented by Dr. Silas Weir Mitchell in 1864. Mitchell observed soldiers with high-velocity gunshot wounds who developed a burning pain long after their wounds had physically healed. He coined the term causalgia from the Greek words for burning heat. It was the first formal recognition of this systemic failure. By the early 20th century, the medical community evolved the term to reflex sympathetic dystrophy, or RSD. The theory suggested the fight-or-flight response was trapped in a self-perpetuating loop of pain and vascular response. In 1994, the IASP officially renamed it CRPS, recognizing its complexity beyond just the sympathetic nervous system. We now view CRPS through a triad: neurogenic inflammation, autonomic dysfunction, and maladaptive neuroplasticity. This triad creates a multi-system failure where the immune, neural, and vascular systems become dysregulated. A central driver of CRPS is glial cell signaling. Glia are the immune cells of your nervous system, acting as its primary regulators. Microglia shift from a resting, surveying state to an activated state, releasing a cascade of pro-inflammatory cytokines. These cytokines, IL-1V, TNF-A, and IL-6, effectively crank up the volume on pain signals in the spinal cord. While microglia initiate the response, astrocytes are responsible for its maintenance, leading to an excess of glutamate in the synaptic cleft. This excess glutamate creates a state of persistent hyperexcitability, locking the nervous system into a state of chronic pain. In the peripheral ganglia, satellite glial cells wrap around sensory neurons, facilitating crosstalk between injured and uninjured nerves. Increased gap junction coupling via connexin 43 allows signals to spread to neighboring uninjured neurons, expanding the area of perceived pain. Recent research highlights the mTOR pathway, a critical molecular switch that regulates protein synthesis and cell growth in chronic pain. Persistent activation of mTORC1 locks the nervous system into a high sensitivity state, while mTORC2 regulates cytoskeletal rearrangement. The metabolic terrain of CRPS involves a mitochondrial crisis where cells cannot produce enough ATP to maintain normal nerve function. Oxidative stress damages mitochondrial proteins and reduces protective enzymes like MNSOD, further accelerating cellular and nerve damage. Localized hypoxia and high lactate levels suggest a shift toward anaerobic metabolism, making the affected limb hungry for oxygen. Growing consensus suggests an autoimmune etiology, where the body produces autoantibodies that actually activate nerve receptors. These autoantibodies target V2 adrenergic and muscarinic receptors, causing constant vasoconstriction or sensitizing nociceptors to adrenaline. The effectiveness of low-dose intravenous immunoglobulin in some patients provides evidence for this autoimmune mechanism. For clinical diagnosis, we use the Budapest Criteria, requiring disproportionate pain and specific symptoms in 4 categories. Sensory signs include allodynia, pain from stimuli like a bedsheet, and hyperalgesia, which is increased sensitivity to a pinprick. Vasomotor signs involve temperature asymmetry of more than 1 degree Celsius or distinct skin color changes like cyanosis or mottling. Pseudomotor signs involve localized edema, swelling, and hyperhidrosis, which manifests as significant changes in sweating. Motor signs include tremors or dystonia, while trophic changes appear as abnormal hair growth or thin, glossy, creaseless skin. Crucially, a diagnosis requires at least 1 reported symptom in all 4 categories and 1 observed sign in at least 2. In the clinical setting, we see edema that defies normal healing patterns, reflecting a failure of microvascular control. Comparing the affected limb to the healthy one reveals the stark reality of the vasomotor and pseudomotor dysfunction. Trophic changes, like brittle nails or shiny, glassy skin, mark the long-term progression of the disease into a chronic state. This discoloration, often accompanied by a significant drop in temperature, indicates severe microvascular instability. Without intervention, tendons shorten and tighten, leading to permanent claw-like contractures that render the limb unusable. The most profound change happens in the brain. Through fMRI, we can see how CRPS literally rewrites your brain's geography. We see a direct correlation between neural signal intensity and the mean sustained pain levels reported by patients. In the primary somatosensory cortex, the representation of the affected limb frequently shrinks or shifts out of its normal position. A classic finding is the hand representation shifting towards the lip representation, effectively merging the two cortical regions. This smearing manifests clinically as a loss of tactile discrimination. Patients often cannot tell which finger is being touched. The boundaries between digits in the brain become blurred, effectively turning the volume of the pain up while lowering sensory clarity. Reorganization also affects the motor cortex, correlating with clinical signs of neglect-like symptoms where the limb feels alien. Patients describe needing intense mental effort just to move a hand, reflecting this deep-seated structural reorganization in the brain. In some cases, pain spreads to the opposite limb, a phenomenon driven by spinal cord crosstalk between activated glial cells. This spread reflects the systemic nature of the neuroinflammatory process. It is not just in the limb, but in the entire central axis. We must address the scientific failure of the opioid model. For CRPS, opioids are often worse than useless. They can be dangerous. Long-term opioid use leads to opioid-induced hyperalgesia, where the medication actually makes your nervous system more sensitive to pain. Opioids bind to the TLR4 receptors on your glial cells, activating them and further fueling the chronic pain state. This creates a toxic feedback loop where the very medication intended to help is actually accelerating the decline of your nervous system. Historically, we relied on sympathetic nerve blocks, but large-scale reviews show these often provide only temporary, short-term relief. They fail because they only block the symptom, ignoring the systemic neuroinflammatory and nociplastic nature of the disorder. When pain becomes unbearable, some beg for amputation. But as a physician with 30 years of experience, I must warn you. Amputation rarely solves CRPS because the pain is centralized in the brain. It often results in phantom pain that is just as intense. CRPS destroys more than just health. It destroys identity. When you can no longer provide, the economic loss is immediate and compounding. Families buckle under the weight, spouses become nurses, and children become witnesses to a parent's daily, unrelenting agony. At the PATA Institute, we reject assembly line care. We believe in an individualized approach that fixes the underlying terrain. We address the three pillars: regulating the nervous system, restoring metabolic health, and reestablishing functional movement. We change the chemical environment of your nerves. This involves managing insulin sensitivity, gut health, and hormonal balance. By dampening the cytokine-driven inflammatory cycle, we provide your body the raw materials it needs for cellular and nerve repair. We use ketamine infusions not just for relief, but to reset the NMDA receptors and break the cycle of central sensitization. This reset creates a vital window of opportunity, allowing us to introduce therapies that can actually retrain the brain's geography. Through GMI and mirror therapy, we leverage your brain's own neuroplasticity to restore the limb's representation in the cortex. We aim to clear the smear in the brain, restoring clarity of sensation and functional control to the affected limb. Our integrative model combines advanced technology with a deep analytical commitment to fixing your body's underlying balance. Success is not just the absence of pain, it is the restoration of function and the ability to reclaim your identity and your life. Pain is a signal, not a diagnosis. If you are searching for answers, know that there is a path forward that does not rely on shortcuts. Join us at the PATA Institute or find more information online. You are more than your diagnosis. Let us help you find the way back. I am Dr. Gurpreet Singh Pata. Thank you for taking this deep dive into the science of CRPS with us. Stay informed, stay resilient. This documentary was produced to provide deep analytical insights for educational purposes. For a path to reclaim your life, visit painmd.tv. Our mission is to empower patients through metabolic and neurological restoration. Thank you for your commitment to understanding. There is hope in science. There is power in understanding your body's terrain. We look forward to seeing you on the path to recovery. I am Dr. Gurpreet Singh Pata, wishing you health and resilience. Goodbye for now.